And there we go. And let me go down. I think I've got everybody on my list. I think I've got everybody written down. So let me run down, and then if I've missed anybody, we will pick them up. I see Jake, I see Bear, I see Bill Franklin, Gary G, Dennis, Clay Morgan, Eric Brookbinder, Len Sierra, Peter Kafka, J Bob, Janet, Paul Frieda, and Rich Jackson. Is there anybody that I missed?
Spokane Gary.
I said Gary G.
Oh, okay.
Okay.
Sorry.
That's okay. Got. So I think I've got everybody there. The only name I don't recognize is, I don't think I recognize is Clay Morgan. Clay, have you been with us before?
Yes, probably 2 times, but it's been a while.
Okay. I'm just looking on my. Ah, yes. I see that. Okay. Yes. So, and somebody's got their sound turned up just a little bit, which is where we're getting an echo from. I'll turn mine down. So since we don't have anybody that's new, let me run down the list and let me see who needs some time. And then we'll go from there. And by the way, I think most of you probably saw it, but there was a real interesting 45 minutes that we kicked off with last Tuesday. It was really a little less than 45 minutes by the time we got going, where Professor Bill talked to us about a new trial that he's looking at, and most likely will enter, where yet again he was instrumental more than 10 years ago in the primary science that leads to this drug being trialed, which is actually remarkable since it's the second time it's happened to him. So if you want to learn more about that or hear more about that, just listen to the recording from last week. And again, I said it last week, I'll say it again this week. These calls are recorded for a number of reasons. There are a lot of people that listen to them later. There are some people who want to go back and listen again. And if anybody's uncomfortable with that, send me a note, and I will be much more circumspect when I talk to you. But by and large, I think most people who are on the call do know we record and don't have a big issue around that. Okay, let me go down the list. Jake, anything for you tonight? Anything you got to tell us? Want to ask us?
No. Nothing. No questions. Nothing to say.
Okay. Bear, how about you? Anything you would like to talk to us about? You're muted. Maybe you need to unmute.
I was doing some other things. I didn't want to be disturbing people. Probably about 5 minutes, a little later.
Okay. All right. Bill Franklin. Hello. How are you? Anything for you?
Yeah, I got a question for the group.
Okay. Gary Gunville. Anything for you? Gary? You're muted. Do you need to unmute? All right. Well, we'll come back to you. We'll ask you again. Put a little question mark there. Dennis Correa, anything for you?
Eric, I'll give you a 1 minute monthly update here.
That's good. We always like that. Clay Morgan, would you like some time tonight?
Yes, if I could, I wanted to get any input anybody has on immunotherapy.
Absolutely.
I'm starting a clinical trial. So.
Okay. Eric, I know you need some time. We'll put you in probably up top as well. Len, anything for you?
No, sir. Thank you.
Okay. Peter, anything for you? You may have to unmute. There you go.
If there's time, I have a subject I wouldn't mind just
there is time. We will make time for you, Mr. Kafka.
Okay.
J Bob, anything for you?
Yeah, I got a couple questions. It'll be
okay.
4 minutes.
Janet, separate and apart from your husband, would you like some time?
No, I don't think so.
Okay. Paul Frieda, anything for you?
Yes, I'd like a few minutes.
Okay. Rich Jackson, anything for you?
A quiet month for me. I'll just listen. Thank you.
Okay. You're not going to share that wonderful visage with us like you did on the other. We were all so enamored to see your face on the inner conversation.
I am considerably more casual tonight than I was the other night.
Okay. Well, we will excuse you. Brian Heisey, anything for you tonight, sir?
Nothing for me tonight, thank you.
Okay. And then somebody just joined us on the telephone.
Yeah, that's me, Jay Mills.
Ah, Jay Mills. Okay, would you like some time tonight, Jay?
I don't think so. I don't think so.
Okay. All right. I think I have covered everybody. Since
Did you get Eric? Did you get Eric Buchbinder?
I did.
Okay.
And since Eric and I talked earlier on this afternoon, I would like Eric to share with you what he shared with me and see what the Brains Trust has to say to him. So, Eric, why don't we'll start with you.
Okay, I don't know how much I can do, but I'll try.
Try, yeah.
So last Tuesday I had an MRI, and it was in preparation for going with the immunotherapy group at UCSF. So there are two people running it, Larry Fong, a good friend of Rick's, and Dr. O. I don't even know what his first name is. His last name is O.H., Dr. O. And so Dr. O, in my previous meetings with him, had been very encouraging about, he had several different studies, and he wanted me to go on this one study, and, gave me, 28-page write-up on it. And then when he called me back on Wednesday after he got the results from the MRI, he was very circumspect and said that someone's making noise. Said that the MRI report came back and it was not good, and that I wouldn't be able to go on any of his studies. So he also said that he would coordinate the calls with other doctors. Now, he called my oncologist in Berkeley. I'd only met with him once before, but with Dr. O once before, but he decided that the person who was going to need to tell me the truth was my oncologist in Berkeley. Now, my oncologist in Berkeley, I had also only met once with, but he didn't know any of my history. So the previous oncologist in Berkeley had left to go into private practice. So at any rate, this morning, I got a note that in my chart, which is their UCSF's electronic access, that I had new test results. So, you know, I had, up until that point, I had only knew what Dr. O had told me. I didn't know anything else. So I woke up this morning, I guess it was about 6:30, and I read the whole report. And the whole report was much, much worse than he had indicated. You know, he was just saying, well, it looked like it was spread, and you've got this pain in your back that we can't deal with. Well, it turns out everything has, all the previous tumors have grown a lot. And I now have tumors on my lumbar spine as well as on my ribs. And that the tumors on my spine are pinching my spinal cord to the point that it's critical that something be done, or presumably I'll be paralyzed. But those areas have already been radiated several times, and they won't radiate it again. They, you know, at some point they'll be doing more damage to the spinal cord than they're trying to prevent. So they won't do any more radiation. So what he was really looking for was someone to tell me that it's time to give it up and go to hospice. So I talked to my oncology group in Berkeley, and they have a tumor board that meets every other Wednesday. And so they're going to bring my case up to the tumor board. That doesn't mean that they'll actually have anything that they can do, but at least there'll be a large group of interested people looking at my case. And then my oncologist at UCSF also called, and he was much more encouraging, but you have to remember this was still before I had read the report. This was last week. And said that he felt that there was a trial I could get on, and set up a meeting as soon as he could with me. So I'm having a meeting on Thursday with him. And, you know, he was more encouraging, but I have a distinct feeling that when I get there, he's going to reverse that and say that it doesn't look good. Now Rick wants me to persuade him to put me on a trial anyway, so that's what I'll be doing. I think go in with my guns drawn and ready to fight. You know, it's really you know, it just it essentially sounds like the end of the line. So that's all I got.
Thanks, Dan. And the one thing that I've encouraged Eric to do a couple of things, and then I'd like some of you to maybe chime in and see what other thoughts you have, brainstorm. But what I said to Eric was, if Dr. Agarwal feels that there is a good trial out there, then Eric should follow that. Should be clear that he'd like to participate in the trial. I also suggested that Dr. Agarwal may even want to go back to Dr. O and Dr. Fong and see if it's absolutely certain that Eric is not a candidate for the ES414 trial that we've discussed on this call before. And then the other thing that I encouraged Eric to do is to talk to Dr. B.J. Miller, who has been supporting Eric as his palliative care doc for a couple of years now, and who's very open, and they have an appointment next week, but I think Eric should reach out to him sooner. And a couple of things there. One is just because I know Eric always feels way better after he's talked to BJ. Secondly, because thank goodness Eric's not in pain right now, but taking a lot of pain meds. So it may be worth just exploring if a pump is an option, an intrathecal pump that Professor Bill was speaking about last week with Dr. George Sathier is an option. And then whatever other good advice, inspired advice BJ has, because he always seems to come up with something inspirational. So I really would hope that if nothing else, Eric, you and BJ can at least get on the phone over the next 24 hours, and I mean I can tell you he'll respond to you. So just reach out. You need to reach out, but he'll respond to you.
Rick, I have a quick question. This is the bear. It's really pointed to Eric. I am not familiar with what his history is. Can you give me, Eric, a 2 or 3 sentence about when you were diagnosed, you know, what you've gone through, et cetera, et cetera?
Eric, if you strong enough,
I can do that. Yeah. So I was diagnosed in April of 2014. I had prostatectomy in July of 2014, and as at the end of August, my PSA came back at 2.6. So it was obvious that the cancer had escaped elsewhere. They did some scans, and at that point found that my that I had in my spine in T2 and T3 at that point. And I soon after that went on a trial drug from Gilead. One of the criteria for that trial drug was that you had to have at least 4 mets, and they'd only found 2. But as I pointed out to them, if you can see 2, there's the other 2 at least are there. They're just hiding.
But did you go on Lupron and other standard care in addition?
Absolutely. I went on Lupron. I had been on Lupron and Casodex, and I went through the docetaxel in January of 15. I had the 6 sessions of docetaxel, and I didn't do very well in my health. I lost 30 pounds. And who knows what effect it had on the cancer.
How old are you, Eric?
I'm how old am I? 68. And yeah, so I wasn't quite 65 when I got the disease, and so I got Medicare as soon as I was old enough to, but I was still working, and so I was able to get help through my health insurance from work, although it was pulling nails. It was Anthem, and they were nothing but trouble. But so since then I've been on, the usual fistful of different meds, and the last one I was on was carboplatin and Geptana together, and I was on those for about 5 months. I had 7 sessions, and then I got very sick after the 7th session, and they decided that I should stop that and go on, and that's when we were going to go on the trial. So that happened, relatively recently.
Mm-hmm.
And so
in terms of additional trials, has anyone told you what the potentially negative side effects of these trials might be?
Well, the one that Dr. O was going to put me on had, you know, as I say, had a 28-page write-up on it, and it did say what they have encountered so far. The study is very, very new. They have 4 people on it at UCSF and maybe a total of 15 in the whole country. So
I mean,
it's very new.
My question, I mean, my thoughts, you know, if you say your options at this point seem to be hospice or another clinical trial, is that surely you have to weigh what your quality of life would be with each option. I mean, I know people who chose to go on hospice and were given, you know, 3 months, but wound up living an extra, you know, 9 months because they had very good care and they weren't stressed and anxious and all of their symptoms were addressed and there was no suffering or anything. I would think in terms of a decision about what to do, that quality of life would be a key feature, because it's sort of like one of the oncologists my husband spoke with, when he said, you know, well, you could do chemo as well. And we said, well, how much more survival will you get with chemo? And he said, maybe 6 months. And, well, if it's 5 months of chemo and pretty awful side effects to get 6 months, it doesn't sound like a great trade-off. So, I mean,
in general, the side effects of immunotherapy are they're very specific, and they, in general, are not like the side effects of chemo. The side effects of immunotherapy are usually relating to, how would I say this, pushing too hard on the immune system, so the immune system overreacts and starts attacking everything.
Mm-hmm.
So that's the main side effect that causes trouble with immuno. So, you know, the trial that I was going to be on with Dr. O had been going long enough that they found out that they could not administer the drug in large amounts. So they couldn't go, you know, once a week or once every 2 weeks, because the immune system was attacking the drug that they were putting in and killing it off before it could do anything. So they switched to, or they were switching, that's part of what I would have done, to a pump that gives you very low dosage but continuously. And they were hoping that would work better. They said that they did get several people who had positive responses to the immunotherapy. That is, the immunotherapy was working for them. So it wasn't in every case that it was being attacked by the immune system, but it was the majority of them.
Mm-hmm.
So they couldn't continue that, you know. But you know, it was encouraging that these people had a positive response. You know, all that sounded really good until he decided that he was no longer going to let me be on the study.
But isn't it important to know that the people who had a positive response to understand at what stage their disease was, because maybe it was way earlier than yours?
Well, they're all castrate resistant with multiple METs.
With multiple METs, okay.
That's one of the requirements of the thing.
Okay.
And then I had to have 2 consecutive PSAs that went up.
Uh-huh.
And my PSA, which had never been higher than 28, is now 62. So that part I fulfilled as well.
Yeah.
So, you know, Rick wants me to get in there and if nothing else, see if I can fight with, or get Dr. Agarwal to help me fight with the immune group to let me be on the study anyway. So
how long is the treatment?
Surprisingly, I am still fairly healthy. I am starting to have problems with the tumors on my spinal cord. So I do have I'm having some balance problems and, you know, a few other odds and ends that are obvious that they're coming from the tumors on the spinal cord. I'm sorry, you were trying to say something?
I forgot. My mind isn't working very well. I it was a question, but I forgot.
So
Okay.
let me.
Eric, this is the bear. I appreciate the information. It gives me certainly some perspective. My heart goes out to you, and I mean, there's nothing more to say. I understand, you know, as we all do, how frightening this is. So there's nothing else to say at the moment. Thank you. Again, the best, and hopefully you'll find a way.
You know,
yeah, thank you.
The sad part, or the difficult part is that as men progress through this disease and become more in need of trials, you know, they run up against the trial qualifications that may require that you have a certain level of health in order to enter that trial. And if your numbers don't substantiate, then, you know, it's all too easy to throw someone out of a trial or to refuse them entry in the first place. But some of it's subjective, and the rules can be bent, and it really depends on who's advocating for you. Which is why you know, since Eric has a very good relationship with Agarwal, and he and Dr. Agarwal have been together now since 2016 when Eric went on the Gilead trial. And he also has good relationship with BJ, and you know, it's possible BJ could advocate for you. You know, maybe we can find you, if not this trial, another trial that for which you might be a candidate. And then, of course, there's also, and I know you haven't discussed this at all, but you might want to be discussing the radionuclide trials like the lutetium. I just don't know. I don't know if you're healthy enough to do it, if your bone marrow is healthy enough to do it. Because that's my personal big concern with people doing the lutetium. Just on that note, as a sideline, we heard from Rob today, Rob Beniscus, and he's stabilized, thank goodness, and he's healthy enough to travel, and he's on his way down to Houston later this week to go into the lutetium trial. So, you know, I think that there's discussions. Would anybody else like to talk to Eric?
Eric, this is Peter.
Peter first.
Yeah, my heart goes out to you. I guess, you know, the message to me is that, you know, we're kind of brothers in this. We both were diagnosed about the same time. You've gone through, you know, a lot more hell than I have at this point. But unfortunately, my case is following yours at some level. I don't feel, I still got years, hopefully. But I just, you know, I just feel that the message you bring to me is, you know, you can't turn your back on any of this stuff. You can't, you know, just be Pollyanna. You know, that maybe you need to take risks of doing early chemo or hitting things harder or something like that. I've tended to not take that approach, but I keep thinking about, should I? Because, you know, as you reveal in your situation, you know, a lot of roads you've gone down, you've had hope, but they didn't particularly pan out. So my heart goes out to you. This is a rough road that many of us are on, and a lot of us were diagnosed about the same time as you, and we just can't let our guard down for a moment. So I'm with you, guys. I'm with you, brother.
Someone else
Okay.
want to speak?
Yeah, I did, Rick. Eric, this is Len. Do you know what your white blood cell count is or what your platelet count is? Just wondering why they didn't accept you into the trial. Sometimes they won't do that if your blood counts are too low.
Well, there hadn't been any labs done, so it wasn't on that basis. It was just on the basis of the MRI and the fact that it's encroaching on the spinal cord right now, and you know, the breakthrough of the spinal cord is imminent, and you know, for the trial you have to go into the clinic every 3 times a week for 3 weeks, but you also have to go in the hospital for 3 days to start with, and you know, I'm sure his thought was that you know, that my health wasn't going to allow the amount of surveillance that they wanted to have. And I think the other problem is that, you know, if I have adverse reactions, is it the drug or is it my meds that would have happened anyway? And they wouldn't be able to really tell which it was. And I think that that's probably the major portion of his decision was, you know, would I, you know, I essentially would not be contributing to the study because I would be such an anomaly. So I think that was the reason.
Yeah, I mean, they wouldn't be able to conclude whether the effect was due to the, you know, to the treatment or not, which then kind of compromises the entire clinical trial.
Right.
Okay. Well, look, Eric, each and every one of us is sending you the most positive energy we can. You're in our thoughts. Let me know how you do. Is your sister definitely going with you on Thursday?
Well, I hope so. She hasn't responded, but as I said, she's gone with me on every visit I've had recently.
Well, let us know if she's not, okay? Just let us know. Just confirm with me that somebody's going with you on Thursday, and try and get a note out to BJ tonight that you need to talk to him. I think he'll call you back. And
yeah, very well.
And feel free to call me over the next 2 or 3 days, and hopefully let me know what happens after you see Rahul on Thursday.
And also, I hope to. I mean, not that either you or I expect anything particularly positive to happen, but you know, when I hear from Gabriel Schwartz about the tumor board, that I'll pass that info along.
Okay, hang in.
Okay, thanks.
Bear, you had a quick question.
I don't really have a question. I have an update.
Please give us your update.
Yeah, I guess I've been on Lupron now for 3 months. Zytiga and prednisone for 6 weeks. All the wonderful things that side effects, et cetera, they're happening, but not to any great extent. I was going to be taking Prolia. There've been some issues. End result, I'll be taking Fosomax, I think starting next week, to deal with bone density, et cetera. My PSA and testosterone are low, remain low, and hopefully they will stay that way for a while. Eric, again, it goes back to you because somehow you're the manifestation of all of us. You know, the road that we're all going down. It's frightful. It's certainly scary, and hopefully we're going to find some way to get out of this oncoming train. At the moment, there are no other issues and nothing to address right now. Thank you.
Just a couple of quick questions and one point of discussion, Larry. First of all, did you get a 90-day Lupron shot? And if you did, how did you manage with that?
The answer is no. I chickened out. I'm sticking with 30-day at the moment.
Okay.
It's not that much of an inconvenience. And I did send you something. I don't want to discuss it now, but there is certainly a half-life buildup over time. And let me put it this way. I need to maximize the time that I have, and quality of life is very, very important to me. And if I can avoid complications, I'm going to try to avoid complications.
Okay. Well, most of us have done 90-day shots here, 90 or 120-day shots. And, you know, I think that they're very manageable. But at the same time, if you're happy to go 30 days at a time, go 30 days at a time. On the topic of quality of life, Fosomax doesn't do much for quality of life. And, you know, what I don't really understand is why you're going to do Fosomax instead of doing what most people do, which would either be Zometa or an Xgeva shot. I mean, the Prolia is a little more frequent. But the problem with the Fosomax is you've got to wake up early. You can't eat for an hour. It's a pain in the you know what. It's not a pain in the butt because it's not a shot. It's a pill. But you know, I think that there are a couple of guys on here that have done Fosomax, but most of the guys on here have done either Zometa or Xgeva, and they work fine. So
well, one of the concerns was that the side effects, very negative side effects like wrecking your quality of life, are quite high. They're 3%. You know, that's high. And if you take a shot for 6 months and you're one of the unfortunate people who gets terrible side effects, well, you're stuck with it because the duration of the effectiveness of the shot is 6 months. If you have bad side effects from a drug you're taking on a weekly basis, well, you just stop and then it gets out of your system sooner. So I think that was the main concern.
Well, if you would like to poll the people on this current call who are taking bone strengtheners, I mean, I can only talk from my own experience. I had 3 infusions of Zometa, and I had no side effects at all from them.
Oh no, you were one of the lucky ones. But if you don't want to take the risk, you know, if you go online and look up side effects of Prolia, I mean, there's 200 people there, you know, cursing that they ever took the drug, that they're in misery and hell and horrors.
Right, but
you know, so it's what you're willing to risk or not.
Right, Janet, but it's only the people that have the problems that complain. And
no, I know, but we don't want to be in the 3%.
But you don't know how many millions. Does anybody want to speak to? Does anybody? I mean, I think it's. I feel obligated to ask people. I feel obligated to ask people what their experience has been, because I know when other people listen to this, I don't want to leave an impression that that there are significant side effects, although on occasion, yes, you know, we know some of the dental side effects. But who's used Zometa or Xgeva?
I had 2 or 3 shots of Prolia, 6-month shots, and I did fine with it.
Well, yeah, 97% of people do fine. But the question, Rick, is how risk averse someone is. If you're very risk averse, then you're not going to take the risk, even if it's 3%.
Janet, this is Jake. I've been on Zometa, which is a monthly infusion it'll be 6 years in June next month. And other than feeling like I have the flu for a day or two, just kind of ragged out, I haven't had any noticeable side effects. So, again, you know, 3%, if the true number is 3%, then that is a considerable number. But I'm an example that of someone who hasn't been affected by it. For what it's worth.
This is Eric, and I got osteonecrosis from it. So I lost a piece of my jaw and 3 teeth.
Well, this is a bear. It's not off the table, and I'm inching into it. I don't embrace any of these drugs that I'm taking, that's for sure. The thing is with Fosomax, I can take it for 6 weeks. I still need to clear up some dental issues, and then I can switch over. So it's not a decision that can't be reversed or can't be changed.
Well, it isn't that you're, I mean, it isn't that you're not taking the drug. You are. It's the form in which you're taking it. And
they're all biophosphonates. I understand that.
Fosomax is a bisphosphonate, is it not?
Yes.
Yes.
So
yes.
Fosomax is kind of like is different to Prolia. It's like Zometa. And the only reason I say to you is because I just know people that have done Fosomax, and they all complain about having to get up early and they can't eat, and it gives them regurgitation and So I'm just raising it from the standpoint of quality of life.
Rick, there are so many things related to Zytiga, and 2 hours before and 1 hour after now.
Right.
I mean, I feel like I'm on some sort of regimen no matter which way I turn.
Okay.
The only thing with Fosomax, it's once a week. If it was every day, no way I'd be doing it. I can try it for a month or two, and if I feel, then I would go to Prolia. If I feel there are no adverse effects.
So that's fine. That's a different formulation of the Fosomax then, because I know people that were taking it on a daily basis. But...
No, I know this because I discussed it with a pharmacist.
Fine.
And I am once a week.
Okay. Well, once a week is certainly nowhere near as bad. That. I was thinking when you said Fosomax, daily Fosomax.
Absolutely not. No.
Okay.
Larry, do you work out and use weights and keep your muscle mass and your bone strength up?
The answer is yes. I work out every day. I walk.
Great. That's the most important. That's the most important thing you can do, and that'll lessen any kind of side effects from this other stuff because it'll keep your bones healthy.
Okay.
Peter, thanks. Appreciate that.
All right. So we're going to move on to Bill Franklin. Bill, you had a question for us. Are you with us, Bill? I see your mic is on. Maybe you stepped away. All right, I'll come back to you. Let me just do this. Let me just check in with some people that have arrived, see if they need some time. Larry Fish, did you need any time today? Larry? Okay. We'll come back to Larry Fish. Joel Blanchette, we haven't heard from you for a while. Did you need any time today?
Yeah, I'll just give you a status in a couple of minutes.
Okay, we'll come back to you. Ken Anderson, did you need any time today?
Nope, thanks. I'm just listening in.
Good man. Okay. Larry Fish, are you back with us? Okay. Gary Gumville, are you? Would you like some time today?
Hi, Rick. It's Larry. It's me. Trouble getting unmuted.
Oh, sorry.
I'm here. I don't need any time today.
Thanks, Larry.
Eric, I'm so sorry that you're not accepted at this time into the group, into the trial. I really hope something does change, but I've been listening to you for the last years, and I wish you the best.
Gary, would you like some time today?
No, thank you, Rick.
Okay, thanks. Okay, so let's go back to Bill Franklin. Bill, are you with us yet? Okay, so we'll come back to Bill. Dennis, why don't you give us your quick update?
Sure. I just got my monthly blood work done, and the PSA is now being reported as less than 0.1.
Oh, good.
Which is quite remarkable on this Zytiga, prednisone, Lupron combo.
What was it before?
Let's see, I think it was up to around 17 at my initial diagnosis with a Gleason 9.
Wow.
So I had did the docetaxel and so if I started out right with that, then Firmagon, and that switched from the Firmagon to Lupron, and that brought it down. Let's see, I think we were down to about 0.66, and I had a flare up of it, and that's why I had to change doctors, because my doctor was, even though my PSA was doubling every few months, he said I was doing just fine, and I took it in my own hands and said no. So found another doctor, got the latest scans that were a lot better than what I had had before, and certainly they found a progression with another met in my other femur. I started out with one in the right femur. They found a new one in the left femur and a new one in my sacrum. I'd already had several in the lumbar area. So that's when I got on the Zytiga. And it's been working really good for me, going down and down. And, the side effects were not much greater than what I had already with the Lupron. I don't know that I could really quantify and say that the side effects were worse after I added the Zytiga. The prednisone is 2.5 milligrams twice a day, and that has given me an advantage for my other problems I had, like arthritis, and I could hardly stand up from a chair, and after when I did, I'd have to stand there for a while. I felt like my hips were going to collapse, or my legs were like two telephone poles. But since I started the prednisone, that stuff is like all gone away. So I mean, I'm feeling as good as I possibly can. But on this bone issue thing, I've been on from my initial diagnosis pretty heavy dose of calcium D3 a couple times a day, and without any adverse side effects. And my DEXA scans have been actually improving a little bit. My baseline that was showing some osteopenia, pre-osteoporosis, and the last one I had earlier this year, so no sign of any osteoporosis. So for me, and my docs have both said, we may want to look at one of these other bone strengthening drugs someplace down the line. And I had my dentist review, my dental conditions, everything was fine. Had no problem if I have to go on it. But I'm just, again, it's another drug and more side effects, and looking at the data being the DEXA scans are showing I'm not progressing in that way. So my choice is to keep feeling good and doing what I'm doing with my exercising and my golf, and quality of life has been really good.
Speaking of which, how's that golf game?
Oh yeah, I played today.
Good.
Had another very good round today. Unfortunately, though, it was a team game, and the rest of my team members let me down.
Okay.
So we didn't win anything today.
Okay. Well, you let me know next time you're in Tubac, and we'll have a drink. We need to have a drink. Anybody want to just comment or review or talk to Dennis before we move on? Okay. All right. Well, that's all good news, Dennis, and I'd love to hear it. As they say,
Congratulations.
Keep
Dennis,
taking the pills.
keep it up.
Yep, I'm doing what I'm supposed to be doing, and it's allowing me to get out and do the stuff I like to do, and driving my car and doing stuff like that. So, yep.
That's right.
Enjoying it.
Okay.
Good news.
Bill Franklin, are you back with us?
Yeah, I am. Had a small issue to take care of. Sorry about that.
No worries. Go ahead. You got the floor.
Yeah, just a pretty easy question for the group. For those of you that were on like ADT or something, and then you stopped, you got, or even any other kind of follow-up where they had you after surgery or whatever. My docs had me going every 3 months, but after the third month, he said, you know, my PSA was 0, my testosterone had risen a little bit. He said, okay, you want to test again in 6 months. And I said, well, I'd still be, you know, comfortable with a 3-month window. And again, this time he said the same thing, 6 months again. So I was like, I want to do 3 months. So he's doing it because I'm asking, and insurance will pay for it. But what was the pattern for everybody else?
Well, I'll tell you. So I should just preface this by saying that Bill was like me, where we got ADT as part of our initial treatment. When we were never on intermittent therapy. We were on therapy that included 12, 18, 24 months, 36 months, whatever it was, of ADT. So when I first came off Bill, I tested monthly for several months. And it was a little unnerving because my PSA increased every month for almost a year. When it didn't show. I didn't show any PSA for about 4 to 6 months. And then when I did show, it just went up each month, and each month my doc would say, don't worry about it, it's going to turn around, and I would say, okay, and then I figured, look, if it doesn't turn around, I'm just going to have to go back on ADT and deal with the consequences. And it did turn around in the end, but I probably stayed on monthly testing for about 18 months, and then I went to 3 months, and I did that for at least a year or more. And then I went to 6 months. And then after about 3 or 4 years, I went to a year.
Okay.
Is there anyone else on the call who got ADT as part of their initial treatment and then stopped? I don't think.
Yes, I did. And for a long time, I was on monthly testing, and now I just recently went on 6 weeks. But I'm a big fan of monthly testing, and my doctor is too, or 6 weeks. I don't think I'd feel comfortable going to 3 weeks. And that's with monthly testing. That's how I picked up my reoccurrence.
Yeah. Yeah, but Peter, you're in a different situation though, in the sense that your disease after your surgery, you knew it was recurring. So you wanted to keep very close tracks on it. And that's different. That's sort of different from Bill, where he went through. Well, is it different from you, Bill, or am I wrong here?
No, I had the prostatectomy, and then very shortly after surgery, I had a rise in PSA, so I went on ADT right away. So surgery was in October. I think I started PSA probably late November, because I was showing a rise 6 weeks after surgery. So.
And you're still on ADT now?
No, I did just shy of about 22 months, and I got off last August, and I've been off since then. And so the second time, which was February, when I came up with a 0, he said, okay, you want to go to 6 months? And I said, no,
okay.
I want to go to 3. So.
Okay, I went off of ADT for about a year and a half.
Right. Yeah, I remember that.
Right about that point, I was still testing monthly. Right about the point, I started climbing and doubling every. My first double was last September to October, and I kept tracking it, and I went for a scan because I had 3 or 4 months of doubling every 7 weeks. So,
right.
I was watching it like a hawk, and so was my oncologist. he didn't have any problem with that. And now recently he told me, let's do 6 weeks instead of a month. See what my next test is.
Well, I'm okay with 3 months. I don't know why he keeps wanting to say 6. You know, maybe that's just his protocol.
I'd stay on it if I were you.
Yeah, I'm more comfortable with the 3 months. I don't know if I could do the monthly. I get nervous, you know, as I get close. So, I can kind of forget it.
It's Len. You just answered your own question right there. If you're comfortable with 3 months as opposed to 6, that's what you should do. And you should just let him know, hey, I'm comfortable with 3 months. I'm not comfortable with 6. And I'm sure he'll go along with that. And hopefully you won't have that same discussion next time.
Oh, yeah. And, you know, he just might forget that we had the discussion 3 months prior, you know, and mention 6 months again. I don't know. But, I mean, he listens to me every time I say it. I say, in 3 months, I want another test. He's like, oh, yeah, okay. He doesn't give me an argument. That's not me. I was just wondering if anybody else had experienced, because it sounded pretty common in the last couple of years, listening to people on the group, that when you go into like a monitoring kind of situation, that every 3 months seemed pretty standard for PSA testing. And as Rick said, some people were doing monthly, but so I was just wondering if anybody else, if their doctor was pushing for a longer period pretty early in the initial checking stage.
The only trouble with 3 month testing in my experience is that you can't really see a trend of doubling if it's a doubling trend of less than 3 months.
Right.
For monitoring it for quite a while.
Yeah, and so mine's been 0 every time. This is the 3rd time, I guess. So, if there's ever an indication at a test, I guess I would ask for a more frequent test to check that kind of thing.
It's Larry Fish.
Hey, Larry.
Hi. So, when my PSA started going up about a year ago, we switched to monthly PSA tests and 3 month scans because it had been doubling once the doubling time came down to a couple of months. And that went on for a little while, and then we withdrew Casodex and it dropped. So I'm in that kind of post. I'm still taking Lupron, but my PSA has been down, came back down to 0.08, 0.11, 0.08, and it's fluctuating. So my doctor now wanted to go to 3 month tests, and I didn't like it so much because, like in the middle, if I start to feel any pains in my hips or my femur or I think my back, I start to get anxious and I want to know something really is progressing that we're not going to catch or something. So I convinced her to see her every 3 months right now, but to get tested every month or every 2 months. So she agreed when I said I wanted that. That's
Okay.
all I wanted. I was able to convince her to test more frequently.
Anybody else want to give their experience, share their experiences with Bill? So, Bill, I absolutely agree with Len that you should insist on what you're most comfortable with.
Right, and he accepts it. He has every time. So it's been twice now, and he didn't balk or anything. I thought it was strange that he was just trying to push me to 6 months testing so early. You know, less than a year off of ADT.
I'm going to go next to Joel Blanchette because we haven't heard from you in such a long time, Joel. That it's got to be 6 months or so, I would think. That I think we'd like to know how you're doing there. What's going on?
Well, I'm sort of the spectrum, but I started out with a car accident, a T-bone accident in October of last year, and then I've been pressed for time buying a new car, and when my car was totaled, and so then Christmas came in the wintertime, in Virginia is too cold for me, so I go down to my condo in South Beach once 10 days every month. So I make several trips down there. And then, of course, my last trip was in March, and then was tax season. So I've just started to see the light of day as far as time. As far as the prostate cancer, I sort of have a bunch of anomalies, and I don't know what to do about it. But my last 4 PSAs have been at 0.2. I saw my urologist who took my prostate out. He sees me for an annual exam now in January. And he told me that when I saw him last, this past January, that I was cured of prostate cancer. And I said, oh my God. So about 12 red flags showed up in my head. And I says, thank you very much. I'll see you next year. And so then I went to a medical oncologist like you had suggested. And the guy says, well, you ought to have your prostate bed radiated. Well, okay. So I already knew that would be a possible treatment. And then, but of course, having listened to Dr. Myers for the past 3-4 years, or 5-6 years, I'm about almost 7 years out from surgery. Dr. Myers has said in his videos that I've watched many times that you've got to be crazy if you do radiation to the prostate bed and you don't know where the cancer is. That's stupid. And so, so I have 3 doctors telling me the 3 different things. I am taking a germline test, as you suggested. Well, I don't know what I'm taking yet, but I'm going to see a germline test practical nurse who only does this for a living, and supposedly he will put me in the right test. There's also this MSI mutation that I'm maybe concerned about, other than just a BRCA1 and BRCA2. BRCA1 and BRCA2. Anyway, my primary care doctor tells me, oh, you probably have prostate tissue left behind, and that's growing. And I said, so, you know, I have a question about that. I mean, have other people had that? And does it actually grow if you have prostate tissue left behind? And you're really not talking about cancer here, you're just talking about prostate tissue. So basically, that's where I am. I'm going to be going to this practical nurse in June, and he's going to schedule me for either Foundation 1 or Guardant or Guardant 360 or Caris Life Sciences or Ambry. So I have no idea where I'm headed after that, but I'm just trying to find out what's going on. So I'm a sort of a quandary. I don't know other than do nothing until something else develops. That's basically where I am.
So let me just say a couple of things, and then I'll throw it open to the guys to see what they suggest to you. But first of all, the germline tests that I'm familiar with are Ambry and Color, which is a very good test. You can look it up, COLOR. Foundation medicine is really a different test. It tests the tumor. It's more of a somatic test. They do have a BRCA test, but I don't think you really need to go there. So I wouldn't even think that that's an option. And also, God tends to be a more complex test that and a lot more expensive, and maybe something you don't need right now. And that's what I'd be talking to the guy about. If it's just plain germline, you could probably get away with either Ambry or Color, and there are guys on this call who have done those tests with those labs. They're not expensive. Frankly, with Color, you don't even need to see somebody first. You can call them up. They'll refer you to a genetic counselor if you would like to see one, but they don't require it. And as far as MSI is concerned, I mean, that's really much further down the line. Thank God it's not something that really should concern you right now. We don't have Professor Bill on the call, but for men who are looking at certain of the precision medicine immunotherapy drugs, MSI can be very important, but that's not your situation. The second thing that I personally would do if I had, and let me just say that I know a couple of men who have been in your situation, is I would get scanned to see if you can figure out where that prostate tissue is. And there are a couple of ways that you can get scanned. Ideally, you would want to do a PSMA scan because the PSMA scan is sensitive to prostate tissue. That's what the PSMA factor means. It means that the agent is only going to light up cells that express prostate-specific membrane antigen, most but not all, most of which are prostate cells. There are some other cells that express PSMA that are not prostate cells, but not too many, and normally we know where to look for them. Now the question is, how can you get a PSMA scan? You may be eligible, and it's in your part of the world. You may be eligible at the NIH, and some of the guys on the call may be able to help you a little bit with that to give you more information. But for me, the ideal thing for you to do would be a PSMA scan. Failing that, the Axumin scan is very sensitive, and it's not a PSMA. I should just go back and say there are 2 or 3 different types of PSMA scans. The most sensitive uses some sort of F-18 agent, and then beneath that there's a gallium agent, which is also good if you can get into one of those trials, and Peter can talk about that momentarily. Most of the time, people that have a creeping PSA will be doing these scans, but in your case, you know, you've had 4 annual PSAs at 0.2, and so it looks pretty stable. So it suggests that maybe there is some tissue there, but you are post RP, and you do have a 0.2 level, and I do know that some of them will allow you to be tested with that. The Axumin is not PSMA, but it may help you. But I think that what I would be trying to do is figure out where that's coming from. So, you know, with that said, why don't you comment, and then we'll throw it open to the guys.
Yeah, I'm aware of the PSMA scan. I know that UCLA and UCSF have it. They're experimenting with it. I'm aware that it's been around in Europe for 10 years or so. I'm also aware that Cornell and Johns Hopkins are using the PSMA on the as a finder of the cancer, and then I don't know how it works, but they inject something and it actually kills the cancer that the PSMA scan finds. Right. So that's an experimental stage, I believe. So yes, I totally agree with you, by the way. I need a scan that is more sensitive than of course, the choline and the acetate scan.
Right.
But of course, I don't know if insurance pays for any of this. Those are the things that I would have to look into. Maybe you guys know. I do have TRICARE and Medicare. And yeah, I'll throw it out there and see if anybody else has any ideas.
Peter, can you put those headphones back on, or don't put those headphones back on? But you the man with this.
You can hear me without them, right? Can you hear me?
Yeah.
Can you hear me without them?
Not only can we hear you, but we see your beautiful face much better without them.
Okay. Yeah, good question. So you've not had radiation yet. You've just had an RP, correct?
I had an RP almost 7 years ago, and I have done nothing since. My highest PSA ever was 3.8 before I had the RP, and since then it's been crawling up to 0.2, where it's been for the last 3-month periods.
So about a year you've been at 0.2.
Exactly.
Okay. I don't know what to say. I mean, I think and you have an oncologist working with you. Who's your doctor?
My oncologist is now telling, no, not the oncologist, my prostate surgeon told me that I was cured of prostate cancer, which I didn't believe. And that I also have I've talked to a radiation oncologist in the past, but I went to a medical oncologist, and he wants me to get radiation. And of course, Dr. Myers has always said, you're stupid if you don't know where the cancer is and you radiate an area of your body for nothing with the side effects.
Right. Yeah, well, I mean, you're kind of in a standard situation. I had my follow-up radiation 11 months after my surgery, and I had it when my PSA went to 0.2, and it took about 11 months to do that. And then I had radiation. And many people do have IMRT to the prostate bed as a follow-up thing when it reaches about 0.2 or 0.3 or 0.4 or whatever. So, you know, I don't know what to say. I mean, I'd really be surprised if your cancer had been metastatic at this point. It's probably something that's in the prostate bed, is my guess. But if you've gone a year and it's still only 0.2, you might try to go see if you can make it another year and see if it stays at 0.2 before you jump into radiation. I don't know if it's necessary to go into elaborate scans at this time and go fishing for something that you might not want to deal with right now.
Well, it's 7 years.
To me, that's what I would do.
Peter, he's gone 7 years with that, but he's been stable for the last year at 0.2.
Right, exactly. I'd try to go another year and see if you're stable. I wouldn't. If it was me, I wouldn't go fishing with more elaborate scans right now. You're in good shape.
Right, I understand what you're saying. What Rick said a moment ago that would learn something new was that the PSMA scan will also detect if it's prostate tissue more than if it's prostate cancer. So that's something that I didn't know.
Yeah. So let me just explain a couple of things. One is that, yes, this PSMA technology is being used both to treat and to diagnose. So to treat, it's being used with drugs with radionuclides like lutetium for treatment. Right. But it's also being combined with drugs like gallium and F-18 for screening purposes. Now, I put in the chat window for you just now a trial that I think is the NCI trial that's being run out of Bethesda, Maryland. It's an NIH trial. It's recruiting. It's an NCI trial that's being run out of NIH in Bethesda, Maryland, which is relatively close to you. And you can click on that link. It'll bring it up, and it'll tell you whether you are eligible. You might be eligible. If the 0.2 was worrying me, let me ask you, between the time that you had the surgery 7 years ago and now, have you slowly crept up to this 0.2 level, or have you been?
Yes, it started at 6 months. I went to 0.02, and then 0.4, 0.7, 0.9, 1.1, and then again crept up again for another 3 years to 0.2, and I've been stable for 1 year at 0.2.
Okay. Well, I mean, you know, I don't think I would jump into, if it were me, I wouldn't want to jump into radiation without having a little more information. And I think the information I would need, if I could get myself into one of these PSMA trials, and this one at Maryland is the best. That is the best agent that's available right now, according to some of the reviews that we've read, and I can send those to you if you're interested. But if you can get yourself into that trial and you may be eligible for it, that would be a really good thing to do. And I would be looking, I'd be looking to do a PSMA scan. I think if it were me, if I'd been creeping up slowly over that period of time. And based on the information, maybe I'm a little different to Peter, but that's what I would choose to do. Some people may just say, look, it hasn't been moving much, sit on it. But I think, it's better if you're proactive. If you can find something there and it needs radiated, if you can clearly see it's something that's in the that could have been left over from the surgery, that's the trouble. I mean, it's going to highlight. But it's going to highlight prostate cells, and then you've got to figure out, well, are those cells cancerous or are they not cancerous? And even if they're in an area where the prostate was, it's only through biopsying them that you would know whether they were cancerous or not.
Right. Yeah. I wasn't aware that NIH had a PSMA scan available. All I know is that one of our speakers was a radiation oncologist at a prostate cancer support group, and he was sending people to NIH all the time with as low as 0.3, he said. So I was I thought that NIH was only good for only took advanced prostate cancer patients. I wasn't aware that they would take somebody with a 0.3. But maybe that's why he's sending his patients there, because they're getting a PSMA scan.
Well, why don't you? I forget the scan. I'd need to go back and read it, but you can read it. You're on GoTo. You're with us on GoToMeeting, are you not, Joel? Or are you on the telephone?
Yes,
no, you're
correct.
on GoToMeeting. So open the chat window and just click on that link.
Yeah, I see it. Thank you. Yes, appreciate it.
Okay.
Joel, one more thing. I mean, these scans, yes, they are sensitive. They do pick up things at a low level, but mine went from 0.08, and I got my scan when it was 0.75, and my doctor for the gallium-68 PSMA wanted it to be around 1, 0.75 to 1, because at that level, it picks up a lot more possible hotspot. At the 0.2 level, it might not pick up much. The odds of finding a lot of stuff are much less, and certainly with an oximent, it's even less. So talk to the doctor about this. Talk to the person who runs the trial. They always have a phone number of the person to talk to, and see if you qualify, and talk to them about the possibilities. But it might be too low a level to really even do.
Well, Peter, I think that if you've got to read the trial. So the trial says, I'm going to put it in the chat window what the trial says, and I don't disagree with what you're saying about the higher you are, the better it's going to be. But the trial says, I just put it in the chat window, it says non-specific or no evidence of disease on standard imaging modality and biochemical prostate cancer relapse with a PSA greater than 0.2 milligrams. So it could well be that you are eligible. I don't know. Are you testing with ultrasensitive or just regular?
Regular, as far as I know. I had 0.01 after my surgery.
Okay, so if you test and you're over 0.2, you could be eligible. And then I absolutely agree with what Peter says. Talk to the trial docs there. I mean, the whole purpose of this trial is to see whether men that have recurrent disease can be diagnosed earlier and earlier. That's why they're doing the trial. So, that maybe it's helpful to them that they've got a guy that's got a history like yours. But I would want to consider it, and whether it's worth. I mean, the medical oncologist that you went to see, was it a GU med onc or was it just a general medical oncologist?
Good question. I don't know the answer to that.
Well, the other thing is to get a good GU med onc and go have a chat with them and see whether they think you should go into the trial or not. But I like Peter's idea of calling the people on the trial. NIH is usually pretty easy to work with, and I'm sure they'll get back to you, and you've got all the information there, and they're local to you.
Yes, that's correct. Yes, very good.
And I heard, although it doesn't know, it may other people that listen in, I had heard that they were paying expenses to get this trial.
One thing I forgot to tell you, because I had biochemical recurrence at 0.2, I did get another bone scan and another 3T MRI, 3 Tesla MRI, but they showed up negative.
Okay.
Because they don't.
It seems to me that you're right in the sights of this cohort 2 on the trial. But let us know, will you, Joe? Don't be a stranger. How about this car accident? Is everything okay after that?
Well, I hit my head against the driver's window pretty hard, and on the same day I went to the hospital and they checked it out and proved nothing. But I've been getting some slight headaches lately, and I'm not a guy who's ever had a headache all my life, so I'm a little concerned. But anyway, the doc says if it continues, they'll get me some more scans or whatever.
Okay.
So this is Gary. Can I ask, because I'm kind of in this a little bit earlier, but kind of the same situation as Joel. And my first thought is, I understand that the scans won't pick up anything. What is it? And I guess you're saying, Dr. Myers is saying, why radiate the prostate bed when you don't know anything? But it seems to me the earlier you get to something, the better chance you have that you can actually get rid of it. So why is it, what's making you not want to do that? So to me, it just seems like it would make sense to radiate the prostate bed.
Well, the doctors, my surgeon's been telling me he thinks it's prostate tissue left behind, so why radiate prostate tissue when it's not cancer? He's convinced that I'm cured of cancer, which I don't agree with him, but as far as the radiation does have some side effects, you could damage your surrounding organs and so on. So that's one of the hesitations. So the best solution would be to find the cancer and then radiate it where it is. So I know a lot of other men are in the same boat, because it's only lately, in the last 3-4 years, we had more sensitive tests to use so we can find out where the cancer is, but they haven't got it perfect yet. And we're still waiting a better resolution on the scans. And yes, I agree with Peter that the lower your PSA, the less chance there'll be of finding the cancer. I think the UCLA says it's a 40% chance of finding it. Then if you're at 0.3 or 0.4, then you have a 60% chance of finding it, and so on. So yeah, I could take a scan and still be negative. So we just don't know until I do it if I go that route.
I think Gary, to answer your question, what if this was something in the lymph nodes? What if there was something there, but it was in the lymph nodes, and we'd be radiating the prostate bed, but we don't know that it's in the prostate bed, particularly given the nature of the way that it sort of crept up very slowly over time. So if we could figure out where it was, it would be better off. If you wanted to open yourself up to full pelvic girdle radiation, then yeah, you cover everything, but not everybody wants to do that. But I think that if it were me and I was going to do radiation, I wouldn't just do the prostate bed. I would do the whole pelvic girdle and cover the lymph nodes too, if it were me.
All right.
All right. So, let us know how you do. there's a couple of things. Follow up on that scan, see what else is available in terms of gallium-68, if you count. But I think you're right in the sights on this NIH scan. And get yourself a GU Med-Onc on board. You need a good GU Med-Onc on board.
Right.
Okay. All
Now
right.
you recommended one to me. That's John Hopkins, so I might go to him.
Yeah, Antanarachis is good. You know,
Right.
you can't go wrong with Antanarachis. There's a woman at George Washington in D.C., but I don't know if I can give you a name. But I think if it was between them, she supervised a trial that that Tebow was on, and I can certainly I have her name in Tebow's records. But I think I would prefer Antanarachis for for the sake of driving another 30 miles or so, 40 miles.
Right.
All right, let's move along here and talk to Clay Morgan. Clay, tell us you had some questions about immunotherapy. Tell us how you're doing and you tell us what your questions are.
Well, I'm just kind of to refresh everybody. I was diagnosed 2010, 2011, had Gleason 9, had RP and ADT, and in 2016 PSA started rising, so went on Xtandi, and then that fell in late 2017, and then since then I've kind of been looking for clinical trials versus going on to chemotherapy. And so I was able to find a clinical trial nearby me here in Portland, Oregon at OHSU with pembrolizumab or Keytruda. And I'm actually starting that on Wednesday in a couple of days, where they'll do 4 treatments and then monitor, and then if necessary do 4 more every 3 weeks. And I had some concern about side effects, quite a bit of concern actually, based on commercials, but also the summary that they give you. But in the end, I feel like it's a good thing to do. But they're combining the Keytruda with Xtandi. There's some interaction between the two once Xtandi fails.
What's your current PSA?
Current PSA is 64.
So I have a 53 here, but I didn't put when it was, so I don't know how long ago that was.
Yeah, it was 53. I can't remember. The maybe 6 weeks ago, or maybe even 3 months ago. But it's now up to 64, I believe, is where it's at. The last time I had it checked, maybe 2-3 weeks ago.
Okay, so the first thing I would say to you is, can you turn your volume down just a tad, because we're getting some feedback, that might take care of it.
Okay.
The first thing I would recommend that you do is to listen to Professor Bill last week, because he spoke at length about being on Keytruda pembrolizumab, and he also offered to speak to anybody who's going on it to talk to them about side effects. But he actually addressed his side effects on the first 45 minutes, or roughly.
Is that last week, you said?
Last week, yes. It's on our website, amcam.org, under recordings and decks, and it's also on our YouTube.
Okay.
So I think
and it's
you'll find
Professor
that
Bill.
Bill Burhans, Professor Bill Burhans, Burhans.
Okay.
And listen to that, and then if you'd like more information, send me an email, and I'll connect you to Bill with the greatest of pleasure.
Okay.
The pembrolizumab did not work for him. He had 3 infusions, and it didn't work. And he's now going on with another trial at Dana-Farber, which he discusses on the slide. The question I have for you is, have they measured your MSI and your MMR?
Not that I'm aware. No, not that I'm aware of. They're taking a biopsy tomorrow, but
Okay. And so, you know, it's always very smart before you get onto these trials, at least in my opinion, and I think it's something that I would want to do, is to try and biopsy and get that biopsy read first. And the reason for that is we want to know what's actionable. And if, for example, you have a very low MSI, microsatellite instability, it's likely that the pembrolizumab is not going to work. On the other hand, if you've got a high, it is likely that it's going to work. Something else may show up, some other type of mutation. And I'm always concerned about people that jump into immunotherapies before they've had their tumor sequenced. Because the information that you're going to gather from getting your tumor sequenced is going to dictate what type of precision medicine you're suitable for.
right.
And so I would want to see that result if it were me before I started getting the drug.
Okay.
Is there anybody else that wants to address? I'm not sure. Is anyone else feeling pembrolizumab Keytruda on this call, or is there anyone else that would like to talk to Clay about this trial that he's been entered into?
Clay, this is Jake. We're still getting a lot of echo from your phone, so would you mind muting yourself until you're ready to speak? Thank you.
Clay, this is Peter. Besides the genetic testing that Rick is talking about, have you ever had germline genetic testing? The reason I asked is because I had germline testing, and I have a genetic mutation that, lo and behold, responds to Keytruda. So I suspect it's going to be sometime in my future that I'll be going down that path, because it doesn't necessarily mean it's going to change anything, but because pembrolizumab is effective seemingly in a number of cases with the particular genetic mutation I have. I don't know if it's going to work or not, but I was wondering if you ever did have germline genetic testing.
Yes, I actually did, and right now, no. In 29 mutations they tested for, none of them showed up. So nothing in the germline.
Okay.
Where are they going to biopsy? Where is there a spot to biopsy?
In a lymph node. I have 3 lymph nodes that are now, showing growth.
Okay. Which reminds me, I have to check in with Professor Bill and find out if he had any results. They also biopsied his lymph node about a week and a half ago, but I think it's going to take a little longer for him to get the information back. I mean, again, he went into the Keytruda, or he got Keytruda. I don't think his was with a trial without having that detailed information. And then he found out pretty quickly that he wasn't responding to it. But I think it's terrific that they are doing this. because it's OHSU, they're probably going to send it to the Dream Team for analysis. And the problem with that is it takes about 6 weeks to turn it around. So you might want to ask them or insist, because they're not going to probably want to do it, but you might want to insist that they also send a sample down to Foundation Medicine, because the turnaround time there is going to be about 2 weeks. And that should now be covered by insurance, or if it isn't, I can work with you and the people at Foundation Medicine so that they're going to pick up the large share of that. Foundation Medicine has not been billing people to date beyond what the insurance will pay. And
they'll look at the MSI.
And they measure, well, so will OHSU, or the Dream Team will measure that. But the problem with the Dream Team analysis is it takes forever. It's done at OHSU for the whole of the Dream Team West. They send everything up there, but it takes them about 6 weeks to do it. Well, you may finish up going through 3 or 4 lots like Bill did, and then find out that it's not working, whereas you might know within a week or 2 weeks that it wouldn't work if you get results back, but something else might work. So if they've got enough tissue that they're getting out, it doesn't hurt to send it down to Foundation Medicine as well. But you're going to have to be very proactive in your own cause to get them to do that. But I can help you on the Foundation Medicine side. We can help you on the Foundation Medicine side if OHSU agrees. Who's running the trial at OHSU?
Dr. Julie Graff.
Yeah, I've seen her name. I don't know of her, but I have seen her name. I've seen her published. And, but see if you can get them to do that. And you know, again, I'm sort of surprised that they allow you into the trial before they sequence you.
I think that's just part of the trial. They're studying. That's the main thing they're studying is why it's failing for some people, why it's not failing for others.
Yeah. Okay. Well, I can see. We can see it would be part and parcel, but from a patient standpoint, I think the patient would want to know that they are receptive to the medicine, to the drug before they take it. I can see why the researchers might not care so much, but from a patient standpoint, which is what we're about on this call, it would be nice to know. But either way, it's not a bad move. It's a positive move that you're in this trial. It's a positive move that you're doing it, but the more information you can get, the better you are. Anybody else want to comment to Clay before we move on?
This is
Jay.
Current. Well, I don't know what I had applies or not. I had Provenge for 4 weeks, but that's probably something different, immunotherapy.
Yeah, I mean, Provenge is certainly different, and it's something. If it were me, I would definitely get it as early as I could. I mean, it requires 3 successive rises in your PSA when you are castrate resistant. And whilst we don't really understand how good a job it does, and it's hard to measure, I think it definitely has a positive impact. But it's not going to be as precision and have as dramatic an impact as something like one of these precision medicines would have.
Okay.
Len, did you want to say anything on this?
Well, I'm kind of surprised, like you, that they're not doing biomarker analysis before they accept patients. But like Clay said, they probably will be doing that while they're giving you the drug. But I know that PDL1 is a marker they like to see when they treat you with pembrolizumab. I know Bill did not have PDL1. I know the microsatellite instability is another one, but I don't know.
Okay.
It's I think pembrolizumab, it's got less than a 25% efficacy rate in prostate cancer. So if it were me, I'd want to know if I had PDL1 before I went through it, because there is, of course, there is a chance of autoimmune diseases, inflammatory bowel disease, some pretty serious side effects. But good luck. Talk to your doc about PDL1.
Okay, appreciate both of your inputs.
Okay, and listen to Bill, and then let us know if you'd like to speak to Bill one-on-one.
Okay, I'll do that. Thank you.
Okay. So we've got 20 minutes. Hopefully we can get around everybody. Peter, did you have something you wanted to bring up?
Yeah, kind of obscure question here. You know, maybe it's a little bit naive at this stage in the game for me, but are there, besides your PSA, has anybody who's gone castrate resistant noticed any other changes, any other dynamics in terms of how you respond to drugs and so forth? Are there any physical characteristics changes that are noticed other than just tracking the PSA? You know, what determines your loss of sensitivity to Lupron, or in my case, Lupron and Zytiga? What makes it determine that you're castrate resistant as opposed to still?
I'm wrestling a little bit with the question. I want to try and rephrase it for people to answer. Are you saying that what are the signs of castrate resistance other than PSA increasing? Is that the question?
Yeah, kind of. I go through in my head, you know, I'm on my second month of finished my second month of Zytiga, and I'm on Lupron, but I was on Lupron and Casodex for 18 months, and now I'm back on ADT. I feel absolutely no side effects. I mean, I feel the same as I did 3 months ago as I do today.
Okay.
It keeps going through my head. How do you know if this stuff is working besides the PSA? I'm going to get a PSA test when I go home in a couple of days. But other than the PSA rising, is there any other effect people sense that says this is no longer working for them?
Well, castrate resistance, I believe, and maybe somebody can check on me and correct me, like somebody like Len can check on me and correct me, but I believe castrate resistance is defined by a rise in the PSA when you are on an ADT drug. And so I don't know what other markers would be expected to necessarily change, because that's what castrate resistance is. The question is what
I guess I'm asking whether there's a lessening of the side effects of those particular drugs if you're no longer sensitive to them.
Well, I think that the side effects from the drugs come from the control of testosterone. So if your testosterone is low, whether or not your PSA is rising, you're still going to experience the side effects, although some people experience worse side effects over time and some people experience better less side effects over time. So it's not the PSA or the change in PSA or the castrate resistance that's causing the side effects. It is the drugs you're taking, and if you're still taking the ADT, the androgen deprivation drug, the LHRH drug, and your testosterone is still at the same level, you're probably not going to feel anything different. And then when you add these other drugs that stop the testosterone being made in other places or in different ways, or stop the testosterone from feeding because it works on the androgen receptors, they are going to have a different set of side effects once you start taking them. Does anybody else want to maybe comment on that? Or Len, go ahead.
Yeah. Peter, how long have you been on Zytiga?
Over 2 months now.
Okay. So I was on Zytiga plus Lupron for 3 months. And, you know, like you, the first 2 months, I felt no different than I did when I was on just the Lupron or the Garrelix. However, the third month, I did start to feel some fatigue. Now, the first 2 months, paradoxically, the PSA was creeping up. Nevertheless, I felt fine. Then the third month, it started coming down, and I still felt fine. So I guess maybe that answers your question. You won't be able to know by the way you feel whether it's working, whether your PSA is going up or down, because hopefully it'll never happen. But usually guys are asymptomatic, at least with regard to the effects of metastases, until they've been castrate resistant for a long time.
Okay, well, that kind of answers my question.
Yeah.
Don't pay any attention to. Just let it ride out for a while.
Yeah, and if your PSA happens to creep up a little bit, don't freak out. It's a known observed phenomenon that there is a flare sometimes associated with initiation of Zytiga.
Okay. Yeah. Okay, that's good information.
Anyone else like to respond to Peter?
This is Jay Curran again. I don't know how scientific this is, Peter, but in my case, I feel that it has made the things that Firmagon was bothering me with more. I feel them more. Sadness and fearfulness and stuff like that.
Interesting. Okay.
Jay, have you discussed with your doctor using an antidepressant, or are you using one?
Yeah, and that was going to be one of my questions. Has anybody used is it Effixor? EFL?
Yes. Okay, so it's good. Let's just we'll come right on to you, because I was going to come to you next, and then lastly to Paul Frieda. But Peter, can we move on? Does that?
Sure. Yeah, move on. Move on.
Okay. So yes, I've used Effexor since 2000. Long before I had prostate cancer. So I'm very, very familiar with venlafaxine as a drug. In fact, I recently switched from the regular pill to the time-release pill at the beginning of this year, and that actually took a little bit of adjusting to. But now I think I'm fine on it. I took it for depression because I've suffered from depression probably most of my life, and in my case, I'm pretty certain it's genetic. It's in It's in my mother's family, seriously. So I am familiar with it. I will tell you that when I went on ADT, on Lupron, and when I suffered, and so I recognized depression. I knew what it was. It wasn't scary to me, but I just knew that I was feeling it. And so I decided to, I talked to my doc about it, and he said to me, just double your meds, which I did. And I doubled my meds for as long as I needed to until I felt that the black cloud lifted, and then I would go back to my regular dose. The venlafaxine did absolutely nothing for the hot flashes. It's often used for people that have hot flashes. For me, it did nothing for that. But I think because my body was too used to it. What I will say to you is that if you are suffering from depression and you believe it is related to being on androgen deprivation therapy, then it's not a bad thing to medicate. The question the question is what drug to use, and that is very much a trial and error. So you have to start a drug, and if it works, it's great, and if it doesn't work, you have to go on to the next drug. I mean, the first drug they gave me when I tried using drugs for depression, these more advanced drugs, because I tried it once in the 80s and it was horrible. The first drug made me suicidal. It was a horrible drug. It was Paxil. It just didn't work for me. It was an SSRI. I then went on to an SNRI, which was the venlafaxine, and it's worked well for me ever since. I know other people that are on venlafaxine, and they have a lot of difficulty with it. So everybody is different, but I do encourage you to try it, to try one, because if you can find the right one, it's going to make you feel a hell of a lot better. Does anybody else want to talk about Effexor or venlafaxine? J. Bob, back to you.
Yes. Back to me. Okay. You don't happen to know your dosage, do you? What he mentioned for me was a low dose.
How much?
He didn't say. He just said just try low dose.
Okay, yeah, I do know my dosage. I am taking 112.5. So that's the equivalent of 1.5 75s, which is what I've been taking for quite some time. But I increased my dose when I started to feel more depressed 2 or 3 years back. When I was diagnosed, I was on 75, and they told me to double it to 150, which is what I did. And then I would cut it back to 75, and then about 2 years ago, it wasn't enough. I could feel it wasn't enough, so I just increased it by half a pill. And then when I went on to the time release, I take a 75 and a 37.5 time release.
Okay. You had asked me for an update a while back, and so I did see Dr. Aguilar, and so we talked about it, and he said I could try reducing my prednisone down to 2.5. So I've done that, 2.5 milligrams.
Twice a day?
And
twice a day?
Once a day in the morning.
Okay.
And I just had PSA test, and it was 5. Before that, it was 6.
Okay.
So I don't know what I can be looking forward to as far as a PSA. Maybe that's around my nadir. I just have to wait and see, I guess.
So, I mean, well, it's still good. I mean, your PSA is heading in the right direction.
Yep.
And the longer that you get out of the Zytiga, the better you are. And how long have you been on it now?
Let's see, since February 5th.
Okay. So, it seems like it's doing the job, especially since you went down from 6 to 5. And it was a lot more. What was it when you went on the PSA on the Zytiga? It was 12, wasn't it?
No, actually, it was 101.
Oh, it was 101. That's right. Okay, and then it went down to 12 right after you started it.
Well, I think it stepped down into 54 and then went to 12 or something like that.
All right, I see now. Yeah, I'm not reading my notes very well, but I have it. So going from in 4 months or so, going from 101 to 5 is a good result.
Okay, my last question. Today I just had my crown put back on. It went out about 2 days ago. Do you think there's a relationship with low testosterone or bone density going down? You don't. Okay.
That's beyond my pay grade. Anybody else want to respond to any of these questions of J. Bob's?
I didn't understand what happened to him. What did he say?
He said that he lost a crown, which he just got refitted, and he's wondering whether losing the crown might have anything to do with bone density issues.
Haven't heard that.
Okay.
I don't. This is Jake. I don't think teeth are like bone. Bone remodels itself and rebuilds itself, and all the time. But teeth pretty much stay the same. So they probably your crown probably just worked loose. It needed to be re-glued.
Thank you.
Okay, and let's give the last couple of minutes to Paul Frieda. Paul.
Okay. There's two things. I had my 3-month shot today, and my doctor wanted to get a baseline for the future, so he had me do a CT scan, and unfortunately came back with a growth on my pancreas, and so I've got an appointment tomorrow with a doctor that's going to try to evaluate it somehow. He was talking about an endoscopy of some kind, and so I'm doing a little reading on the internet, and I'm getting more frightened the more reading that I'm doing.
Right.
Anyway, but my PSA is down, my testosterone is down, and so all that looks pretty good. The other thing I wanted to ask.
Hold on. First,
okay.
Tell us what is your PSA and your PSA.
Oh, PSA less than 0.1.
Okay.
And testosterone less than 20.
Okay. So. And
blood work is good. My blood pressure is amazing, 125 over 82. Most things look good. I have a little deficiency in some of the blood cell counts, but they're just on the borderline. And other than that, my blood work looks very good. So that's that. And but anyway, I've got a symptom that's developed, and where I try to bend my finger and the knuckle cracks, and it really hurts. And so I'm wondering if maybe I'm starting after 30 months of Lupron therapy. Maybe I should start taking some kind of supplements or something. So I'm not taking anything, but I was wondering if I'm I should be doing something like that.
Well, again, another one of mine right on the nose. One of my issues right on the nose. So long before I got diagnosed with the prostate cancer, I noticed that my knuckles were freezing, and when it first happened, it was really painful to release them. And in fact, I got a shot which is a very painful shot in the joint of some steroid of something or the other, cortisone or something. And it did get worse. It definitely got worse when I was on ADT, and it's gotten progressively worse since. But the good news is that you don't notice, I don't notice the pain anymore. So now my fingers lock all the time, and I just and I just straighten them out, and it doesn't hurt anymore. But it happens all the time, every day, and it's the worst when I get up in the morning, and they just lock. Other times I'll be doing something, and they'll lock, and especially if I've got something in my other hand and it locks, it's like impossible because I can't open it. I don't have the strength to open it by trying to flex my fingers, and I don't have the other hand to push the knuckle back. But I will tell you that the pain part of it has ebbed away. So I don't know whether the ADT made it worse or not.
Nothing you can take for it? Apparently not. You would have done that long ago.
I guess I think I talked about it to the doc once. I just deal with it. I mean, it's not worth worrying about. That's enough. Too many other things. Len, go ahead.
Well, Rick, you know Donna Wilson over at MSK.
Yes. Yeah.
She's an oncology nurse, but she morphed into an exercise physiologist of sorts. Anyway, she often has the answer to bizarre questions like this one. And in the case of my case and Richard Foody's case, we both had the same finger problem. She told us to do this. Let's see if I can get my hands right.
Okay.
He told us to make a fist.
Yeah.
Like this.
Yeah.
Hold it, squeeze it tight for a count of 5, 1001, 1002, etc. And then open it up as wide as you can, like that.
Right.
And, do that a sequence of 3 times and do it several times a day.
Okay.
It went away for Richard Foody, it went away for me. Just throwing it out there.
Thank you.
I'm gonna try it because as I do it right now, I feel my fingers locking, but not bad enough that I have the strength to unlock them by doing it. I'm gonna do that, Len. Thank you very much. And tell Donna, when you see Donna next time, you tell her a special thank you from me, okay?
Well, let's make sure it works first.
Okay, now we need to describe it because some people are not going to see what you just did. So what we just did is we clenched our fists and we clenched our fists hard, and then we opened our fists, spread eagled our hands. No, wait a minute. We clenched our fists for a count of 5, correct?
5, yes.
5. We clenched our fists for a count of 5, and then we opened our hands and stretched our fingers out, and then
For another count of 5.
for another count of 5, and we repeated that how many times?
3 times.
3 times.
In succession.
In succession.
And then do it a few times a day.
Okay. Okay. Thank you very
And it
much.
actually made it all go away for you, Lynn, huh?
It did. Completely went away. And for Richard Foody, I don't know if you know him. He's an occasional listener.
Sure. Yeah, I know his name. Sure, very well. Yeah.
Right.
Okay.
All right. Well, thank you for the suggestion.
Okay, Paul.
Okay.
More important, please keep us posted and tell us what they find with this lesion on the pancreas. And do yourself a favor, don't look at the internet any longer on it. Wait till you see the doc. You know enough already. Don't make yourself nuts.
That's a good suggestion. Thank you. I should stop reading. Yeah.
Yeah, whatever you
Really?
do now isn't going to make a difference until you see the doctor tomorrow, and hopefully it's something that's totally benign and we can take care of.
Okay. All right.
Okay. All right, guys. That's it for another session. Our next session will be next Tuesday. Wait a minute. We got 5 Tuesdays. No, we don't have a session next Tuesday. Because we already had 2 this month.
No, is that right? Did we have one on the 1st?
We had, we had one on the 8th.
I don't think we did, Rick.
Oh, no, we didn't.
No.
Sorry, hold on a second. Oh,
Yeah,
you're
you
right.
skipped the 1st.
That's right. Thank you. 29th. We have a session. 29th.
You anticipated this. You skipped the 1st.
That's
So we
right.
had 8th. Okay, right.
Thank you. We have a session next Tuesday on the 29th. And also, we have tomorrow. Perhaps you'd just like to give us a very quick advertisement, Mr. Gunville, because I believe you are moderating tomorrow night's in a conversation.
Wednesday night.
It's actually Wednesday night.
Sorry. Yep.
Mm-hmm. Okay. Yes, and we'd love to hear from any of you guys. We have a lot of people that are maybe new to prostate cancer, but it's really important to hear from people that have been dealing with it for quite a long time. So that helps a lot.
Okay, thanks. In fact, that call's now open to any cancer. So if you have friends that have any sort of cancer and they've got issues around the cancer that are just bothering them emotionally and having just difficulty dealing with cancer, please send them to the call. Tomorrow night we have the Caregivers call. Tomorrow night is the Caregivers call. So any caregivers, more than welcome. And again, that's for any type of cancer. And Thursday night is the male breast cancer call. It's hard to keep all this straight. Okay, that's it for now. And Len, you are beardless. What happened? Where did the...
No, it's still there, Rick, but I usually color it. I didn't color it. It's turning gray.
Oh, you're giving away your secrets, Sierra. Oh.
Never dyed the hair. Never dyed the hair, but yeah, this I have.
Okay. All right.
So
guys.
Peter, why is Peter wearing a jacket? I'm used to seeing him in Maui t-shirt and all of that. So what's going on?
I'm in Minneapolis. I've been in.
No wonder.
I've been in Minnesota for 3 weeks. I go home Wednesday morning.
Oh, okay. It'll get warmer.
All right.
Yeah, I was wondering the same thing. Yeah.
Okay. All right.
Doesn't look
everybody.
like garb. Yeah.
Thanks,
All right. Good night.
everybody, and good night.
Good night.
Bye.
Good night.
Good night, Rick.
Hi, Rick.
Good night.
Hi,
Good night.
guys.
Good night, everybody.